Welcome, everyone. Thank you for joining us for Region 11's monthly webinar series. My name is Brianna Angaseth, and I am part of the Chapter Relations team at HFMA. To kick off this webinar, we would like to thank our sponsors. On the next slide, you'll see the list of our sponsors: AmPlus, Commerce Healthcare, Progressive Management Systems, Parallon, Firm, TCF Capital Solutions, Harris & Harris, Extend Healthcare, Access One, HRG, AccuReg, Novus, Mail My Statements, Brault, Premier, Centauri, TrueBridge, Aberdeen Health, Patient Matters, Argos Health, RMC, EnableComp, State, Sherlock, Eide Bailey, Softtech, OVAC International, and Vitalware. Your participation is requested. There will be a live Q&A during the webinar, so put your questions in the Q&A pod. We'll also be utilizing the chat pod to share information and tips during the session. And now it is my pleasure to introduce Holly Gavin, President of the Nevada chapter of HFMA.
Hi everyone, thank you Brianna. As Brianna mentioned, I'm the current president for the Nevada chapter of HFMA. I'd like to welcome you to today's webinar presented by Advocare. By way of introduction and to add perspective and context to why Advocare always jumps at the opportunity to speak about medical necessity denials, it's essential to know that Advocare's singular focus and only business line is clinical denials. As such, Advocare is a clinical denials revenue recovery company that uses teams of nurses, attorneys, and denial resolution specialists to appeal, overturn, and prevent clinical denials. Today's webinar will be led by two of their key executives, Lori Beck, Advocare's chief nurse, and Stacy Gearhart, their lead attorney and the company's co-founder. Lori is a registered nurse and Advocare's senior vice president of clinical operations. Lori has worked in case management, utilization review for over 15 years for acute care hospitals and revenue recovery companies. She has worked in various healthcare settings, including acute care and ER hospital settings, inpatient rehab, and skilled nursing facilities. Lori has extensive knowledge of healthcare rules and regulations for commercial and government payers and a thorough understanding of internal hospital processes that impact the revenue cycle. Lori received her bachelor's degree in nursing from Florida Southern College and obtained her state of Florida nursing license. Stacy is co-founder and principal of Advocare. She is also an attorney who has devoted her entire career to leveling the playing field between hospitals and payers, ensuring that payers are held accountable every day. Stacy earned her Juris Doctor from Loyola University Law School in New Orleans and her Master's of Law and Health Law from Loyola School of Law in Chicago. Thank you so much.
Thank you. I have to, this is Stacy. I have to apologize. Of course, everything works during practice, but not the moment we kick off. So hopefully you can see the screens now, but you will get the presentation as well, and it will have the chapter sponsors in there. I apologize for that. Again, okay, let's get back on track. So as we review industry reports for denial trends, particularly what's been going on the past couple of years, including 2020 with COVID, what stood out to us is that authorization and medical necessity continue to be top denial reasons. So with that, we'll review today the types of denials we're seeing for authorization and medical necessity issues, the issues we're uncovering as we perform our deep dive root cause analysis on these denials, and opportunities to prevent denials from occurring, as well as what's going on with legislation and industry news. So let's jump into medical necessity denials. Now, before starting any discussion about medical necessity, I always like to review the explanations for the denial codes the payers use on their EOBs to remind myself and those that I'm speaking with, if you have to have a claim denial, and nobody wants a claim denial. But if you have to have one, medical necessity is the denial you want. When the denial is based upon an issue of medical necessity, the payer invites you to change their mind. The team that developed the claim adjustment reason codes and the explanations for each code specifically used the words deemed or identified when drafting the denial reasons, and you can see those highlighted in orange. These words are what we learn in law school, soft words. They have flexibility. Deem is opinion, judgment. There's room for interpretation. The team could have used a hard definition such as CART Code 50. These services are not medically necessary. That's pretty clear, cut, and dry, similar to when you have a contractual issue. You either did get authorization or you didn't. The patient either has coverage or they don't. There's really, it's a hard rule there. But because of this soft language, the opportunity to change the payer's opinion, because of that, we should always try to find a way to bring a denial situation into a realm of medical necessity. With that, our chances of overturning that denial greatly improve. So how do we do that? How do we bring these other denials into a discussion of medical necessity? Well, obviously the easiest denial type to do this with are denials for no prior authorization. The contractual requirement to obtain authorization prior to rendering services is to ensure payers that they will only pay for medically necessary care. Authorizations and medical necessity go hand in hand. However, I just said a few minutes ago that authorizations are a contractual requirement, and either you attempted to obtain authorization or you didn't type of denial. So unfortunately, there is this administrative hurdle you must get past with authorizations before you can argue medical necessity. You must demonstrate that an attempt was made to obtain authorization, but something prevented you from actually obtaining it. The patient presented the wrong insurance at admission. You started the process, but for some reason it wasn't completed, and issues like that. But with those facts, you then turn your attention to medical necessity. And some state legislatures are making it easier to tie authorizations to medical necessity. Several states have passed legislation entitled the Ensuring Transparency in Prior Authorization Act. They've been doing that through 2020 and 2021. And within that act, there is one key provision which is very applicable to this discussion, and that is a definition for medical necessity. This is huge. Medical necessity is not typically defined by statute outside of Medicaid regulations. Not even CMS defines medical necessity. So what's significant about this is that the statutory definition that we see here that states are generally passing does not require that commercial clinical criteria must be met. It focuses on the prudent clinical judgment of the physician. So I looked at the states that are made up here in Region 11. Hawaii comes closest to having a definition of medical necessity. However, I say closest. Within the definition, there is still a provision that in order to be defined as medically necessary, it must have approval by the health plan's medical director. And that's not exactly the type of medical necessity definition we're going for. So having more states enact legislation to standardize the prior authorization process would be fantastic. And luckily, there is a movement to try to do that. But from the handful of states that have enacted legislation, the administrative burden to obtain authorization is not impacted. Remember, it's a contractual requirement to obtain authorization prior to rendering services. But thankfully, we are seeing more and more contracts between providers and payers where this administrative burden is, well, it's not removed, but it is lessened. The penalty for not doing it is lessened. More payers are agreeing that things happen, and as long as in most cases the hospital obtains prior authorization in those off chances when they don't, the hospital shouldn't be penalized. If the hospital can show in those cases that the care the patient received was medically necessary, the services will not be denied for no authorization. They will be paid. If your payer contracts don't include this medical necessity language, or you don't think they do, double check, because sometimes the language is not clearly stated. You have to really read for the words. It might be similar to the last bullet point here, where it says payer may deny payment for hospital services deemed to be not medically necessary. It doesn't mention anything about the requirement to obtain authorization first, and that's okay. When arguing a no authorization denial, throw this contractual language into your argument if you have it and say, yeah, we didn't get authorization. However, as you will see from the enclosed medical documentation, the services were medically necessary, and by contract, you pay for medically necessary care. So please double check your contracts to see if there's anything in there that you can use. So with that backdrop, let's turn our attention to what we're seeing with medical necessity denials. Lori?
Thank you, Stacy. So I want to begin our discussion on inpatient denials, focusing on level of care denials, specifically the inpatient versus observation admissions. This is the most frequent inpatient medical necessity denial and related authorization denials that we see. We're going to discuss four main areas that impact the level of care denials. The first, the clinical documentation needed to support that inpatient admission. Second, we will review the impact of the reliance on a particular clinical criteria set that is used to determine whether inpatient level of care was met. Third, we will discuss the impact of the CMS inpatient-only list, where it says procedures can only be performed on an inpatient basis. And finally, I'm going to address those inpatient admissions that are less than 48 hours long and denials occur as a result of that length of stay. For medical necessity denials, it really comes down to the documentation. That old adage of if it is not documented, it didn't happen, truly applies here. The medical record documentation must clearly demonstrate the patient's acute condition, including the risk status of the patient and comorbid conditions, as well as the treatment being provided. These requirements are known as severity of illness and intensity of service. Severity of illness demonstrates just how sick the patient really is and is based on several factors. It could be your abnormal physical assessment findings, vital signs, lab and diagnostic test results, but it can also include the risk factors and comorbid conditions that are impacting the care and treatment of the patient, as well as failed outpatient treatment. Intensity of service, on the other hand, demonstrates the treatment and services you are providing to your patients. In order to meet medical necessity for inpatient, looking at intensity of service, the treatment you're providing cannot be safely given in an outpatient or a home setting, such as IV medication, or the frequency of the pain or other medication used for symptom control that are given in any other route other than by mouth, and also the need for that close monitoring, whether it's telemetry or neurochecks or urgent surgery. All of those lead to that intensity of service criteria that must be met. But also, the physician's choice of words can also lead to a level of care denial. If the physician notes that a patient is being admitted to, quote, rule out a particular condition, the payer is typically going to automatically jump to observation. More pointedly, if the physician uses the word observation in their documentation, but then there's an inpatient order, you can count on a denial by the payer that inpatient level of care was not needed. I think we can all understand, right, the challenges facing physicians regarding their documentation. They have been documenting the same way for years and years now, and all of a sudden they're being told, you need to change how you're documenting. But with the strong CDI program in place and cooperation with your physician and physician advisors, change truly can occur. We recently brought some documentation issues to one of our clients that we were tracking for their level of care denials that we worked. We showed this data to the physician advisor, who immediately jumped on that issue and offered ongoing education not only to their in-house physicians, but also their physician practices. They did this through formal meetings, formal training, as well as through quarterly newsletter information. And that particular phrasing of using the word observation in their documentation has stopped. It's a very small issue. It is a small win, but it is a start to get the documentation needed. When analyzing the level of care denials to get to the true root cause, we have to start where the denial occurs, and usually that is when the hospital's case management team is reaching out to the payer to request that inpatient authorization. It's at that point that case management would fax over the supporting clinical documentation to the payer, and then they would make their decision whether or not to grant that inpatient approval. But today, most payers have direct access to the hospital's electronic medical records. So you would think this would streamline the process. But we have encountered situations, and perhaps you all have as well, where the payer denies the inpatient admission request, stating that the documentation did not support the inpatient level of care. Fast forward, you then send the medical records as a reconsideration, and that denial is overturned and the inpatient authorization is granted. Why? If they had access to that record, why did they deny it on the front end and then approve it once they got the full medical record? So you have to ask questions such as, is the payer looking at the necessary information in your record to make the right determination? Do they have too much information turned on for the payer to review and make that decision? Has the payer had a change in staff that maybe that staff member at the payer isn't used to the setup of your record and they're missing that key documentation? And could it be a timing issue where the payer looks at your record and then the physician is notating that critical information to prove the inpatient level of care was met, but it was written after the payer had already reviewed the record? So there are two main products that are available for use right now, as you all, I'm sure, are aware, for payers and providers to guide their decisions on whether or not an admission should be inpatient or observation, and they are Interqual and Milliman Care Guidelines, also known as MCG. In just a few days from now, on May 1st, United Healthcare will stop using the Milliman Care Guidelines and will begin using the Interqual criteria for their utilization review for all of their benefit plans. When UHC announced this transition to using MCG to Interqual back in February, we got two primary questions from the hospitals. First, they asked, what is the difference between Interqual and the Milliman Care Guidelines? And second, how will this change impact the admissions for UHC patients to our hospital if we do not use Interqual? So let's first address what the differences are between the two criteria sets. Both are evidence-based clinical criteria used to determine the appropriate admission status of patients, as well as looking at length of stay and also for medical necessity for outpatient services such as diagnostic testing and surgery. While it would seem, right, that the two products would be very similar and they have the same desired outcomes, there are differences, and both the hospitals and the payers vary as to which screening tool they're going to use to guide them in that decision. Please note that most health plans currently do use MCG. When reviewing to determine the appropriate admission status for a patient in an acute hospital, again, there are those two factors, right, severity of illness and intensity of service that must be met. Both of these guidelines do use both of those, but Milliman focuses more on the diagnosis and how sick the patient is when they present to your hospital rather than the treatment. They do address treatment, but not quite. That's not where their focus is. Interqual, on the other hand, they typically focus on both the severity of illness. They've got to be sick enough to be there, but they are also looking at very specific treatment criteria or guidelines that must be met. To the second question we received as to the impact of UHC switch to Interqual on their denials, please remember that these two criteria sets are truly just guidelines, and there's other factors that must be considered when making that decision for level of care. The risk factors, the comorbid conditions, as well as physician judgment. Regardless of which guideline is being used to make those decisions, it's documentation by the physician, and that documentation must be objective and detailed to provide the specific information needed to support both of those areas of how sick the patient is and the treatment, but also include that physician rationale. Two last points I want to leave you with on this topic. First, Medicare does not endorse either Interqual or Milliman for determining level of care. And second, there was nothing noted in that press release from UHC to indicate that they were switching based on any sort of clinical justification basis. UHC bought the revenue cycle company that had one division that was selling the Interqual criteria among all the other things the company offered. And now that UHC owns Interqual, it just makes sense, right, that they would switch to use that criteria. And again, remember that both of these are just guidelines to help in guiding that decision-making process. So now let's talk about the CMS inpatient-only list and how it affects the level of care determinations. As you are aware, the CMS inpatient-only list is being phased out over the next few years and expected to be fully eliminated by the year 2024. This inpatient-only list is a list of procedures developed by CMS and some Medicare Advantage plans and say they will only pay for services if they are done in the inpatient setting, as research shows that they could not be done safely in an outpatient setting, such as, and which includes observation. While on the surface, you would think that this rule would make those determinations for level of care simple for the procedures on that list. But the fact is that the inpatient-only list actually caused other issues. For example, not all Medicare Advantage plans have to follow the CMS inpatient-only list. They don't have to. It's up to each plan to make that decision for themselves if they will or will not follow it. This makes it very, very difficult for hospitals and providers to manage. Because if that particular procedure is on that inpatient-only list and the Medicare Advantage plan follows that list and it gets billed outpatient or under observation, they're not going to pay it. But on the reverse side, right, the same thing can happen. The payer does not follow the CMS inpatient only. The staff makes it inpatient based on that list, and then it's denied saying it doesn't meet inpatient level of care. So it actually caused more confusion. Remember also, right, that the CMS inpatient only list is based on CPT codes, but your inpatient claims are not billed with CPT codes. They are billed with inpatient procedure codes. You know, back in the ICD-9 days, it was a little bit easier to cross-reference the CPT code to that inpatient procedure code, but with ICD-10, there has been much more confusion and much more room for interpretation, causing that cross-reference to be difficult. So while the payer may not recognize the procedure code as an inpatient-only procedure, it then results in a denial of that claim because they're not seeing that CPT code that tells them that it's inpatient only. Because again, those ICD-10 procedure codes cross-code to many different CPT codes. So in discontinuing this list, does this mean that these services now must be done on an outpatient basis? It does not, nor does it mean that your level of care denials will increase. It just means that level of care determinations will now need to be made based on medical necessity criteria or guidelines as previously we discussed. So now I'm going to talk a little bit about the short stay admissions. So regarding the length of admissions, there are some payers who still want to use the fact that an admission was less than 48 hours to make the decision that medical necessity for inpatient was not met. This would be incorrect and also extremely unfair to the hospitals, as medical necessity is never determined by length of time, but by the patient's condition and the treatment plan. Again, severity of illness and intensity of service. Short stay admissions are typically 48 hours or less for their length of stay. Observation care, right, is a well-defined set of services which includes ongoing short-term treatment, assessment, and reassessment before that decision can be made on whether the patient is stable enough to go home or will require further treatment in the hospital as an inpatient. It is very, very important to monitor these short-stay admissions to ensure that medical necessity criteria is met for that conversion to inpatient, and the decision is not based solely on the length of stay. We do see admissions still being converted to inpatient based on that 2-midnight rule, and not always based on medical necessity. In some cases, those conversions would be appropriate, but there must be that physician documentation of the rationale for converting that patient to inpatient. We have seen inpatient orders written same day, and in some cases within hours of discharge. These admissions should also be reviewed and admission status orders adjusted as needed. Having made this statement, it is important to know and understand each payer's billing rules and guidelines as well, as there are some payers that will only reimburse up to 48 hours of observation time, regardless of the number of hours billed as observation, while other payers will require the conversion to inpatient once that observation exceeds 48 hours. The billing and reimbursement for observation hours still requires that the services being provided are medically necessary. So again, the documentation in the record must clearly show the patient's condition, their risk status, and the treatment plan. Medical judgment, the physician judgment, does have a significant impact on proving medical necessity, and the physician documentation of their concerns and their reason is imperative to support that hospital admission, both not only for inpatient but also for observation. So now I want to turn our attention to the length of stay denials. So length of stay denials can occur at the beginning of a stay, in the middle, or at the end of the stay. Most of them occur at the end of the stay, citing a delay in discharge, right? So when the patient is ready to go home, but for some reason, something in that discharge process that stopped or slowed things down, and the payer was unable to be discharged. Payers are truly beginning to closely review length of stay at the beginning of admissions, such as pre-op workup that could have been done, in their view, on an outpatient basis. They're even getting very creative and looking for those denials in the middle of the stay due to a delay in service or a delay in treatment. Payers are saying, hey, it's not our fault your radiology team doesn't work on the weekends, causing you to sit in the hospital as an inpatient over the weekend until you could get that much-needed MRI or that cardiac cath done. Another area for these length of stay denials is the lack of concurrent reviews being submitted to the payer. If a payer has direct access to your records, then this should really not be an issue because they have the clinical information to review and extend that authorization. But if it's a payer where you have to submit those clinicals, by fax or whatever method you use, if those additional clinicals are not sent, it can result in a denial for those additional days. We did have an example where the payer did have access, right, to the hospital's record, but they still denied for lack of clinicals because the hospital failed to release those records for that concurrent ongoing review. So it's not simply about giving them the access. I mean, that's critical, but it's also understanding everybody's role as far as, releasing that information, making sure the payer is reviewing it within the necessary timeframes. The main area for length of stay denials, right, as I spoke about a moment ago, in the middle of those days, is your delay in treatment or service. It could be that there was a delay in getting a specialty consult done, or a delay in a test or procedure due to staffing issues, or even a weekend delay. Delay in discharge is another big area where we're getting these length of stay denials. And in some cases, it's not always the hospital's delay, but it could also be on the payer delay in providing the authorization needed for those post-acute care services. In all of these different types of length of stay denials, again, there's one main key way to prevent or overturning these denials. We've talked about it before. Do you know what it is? If you're thinking documentation, you're absolutely right. What documentation, though, is needed to prevent or overturn these denials? For the length of stays in the beginning or in the middle of the stay, document the reason that the patient had to remain in the hospital until that treatment or service could be provided. Instability of the patient, the high-risk status of some adverse event happening if they were to be sent home, that documentation, again, is key to explain to the payer why sending the patient home to come back to the hospital was not an appropriate decision for that patient. For delays in discharge, document all your discharge planning efforts, all efforts to secure that authorization for post-acute care services. When did you speak to the payer? Who did you speak to? Get reference numbers. That will help get those denials overturned in the event that they deny for length of stay. I have some examples of all three where we were able to get them overturned. And again, we're there in the beginning or the middle of the stay. It comes down to that for example, if they're admitted pre-op, the surgery is not for 2 days, but the patient's in severe pain, right? Get that documented, right? The patient couldn't be home in severe pain. We had to bring him in, even though the surgery was not scheduled for 2 days. So for those, it's all about the patient and the risk status of that patient. But I really want to focus on your delay in discharge and the documentation of your efforts to get those post-acute care services. So we were able to get a denial overturned for a delay in discharge due to the payer's delay, again, the payer's delay in approving and providing authorization for skilled nursing. In many cases, payers are not open on the weekend, right? So your authorization, right, is going to be delayed until Monday or Tuesday of the following week. In this case, when we submitted the medical records, we submitted all of the efforts provided by the hospital. We proved that the delay was on the payer side. The medical director at that payer agreed, right, that there was a delay on their side, but also that the hospital could not discharge that patient safely, and they overturned that denial and paid those remaining outstanding days. So as I said before, extended stays can occur through no fault of the hospital, and yet those days are denied and they go unpaid. So again, making sure that all discharge planning efforts are documented for those delay in discharge. But I want to also talk about documenting the payer's lack of response. Document those efforts, document that they're denying or not giving you that authorization. But we also want to talk about the need to, when we submit those appeals to the payer, that we have screenshots or that information, those reference numbers, to prove to the payer all of the efforts that was taken. And also, look in your contracts. Is there language in there that says that the payer is obligated to pay for those unauthorized days when the delay in discharge is no fault of the hospitals? Very important that you can get that in your contracts. Some hospitals have started to include that in their contracts to have some provision to address those situations in which securing that safe, appropriate discharge plan is difficult, again, due to no fault of the hospital. It could be something historically with the patient. Maybe they had a criminal background. Maybe the treatment is too high for certain skilled nursing facilities to be able to provide that service. So readmissions. Right, these are cases where the payer will deny a claim when an admission has occurred within 30 days of a previous hospital discharge for the same or similar diagnosis. Therefore, the payer is saying not eligible for separate reimbursement. The number of days may vary based on that payer's policy, but 30 days is pretty much the norm. Readmission denials are only for inpatient claims and does not apply if one of the admissions was an outpatient or observation admission. It also only applies to acute care hospital admissions and does not apply if that second admission is to a different type of facility, such as a psychiatric facility or inpatient rehab or an LTAC, etc. Only acute hospital to acute hospitals. Most payers have their own readmission policies that outline exclusions for when a claim cannot be denied for readmission. Those policies are available on the payer's website, and if there are any changes, the payers are contractually obligated to notify your facility ahead of time. Exclusions vary by payer, so it is necessary to understand the exclusions for each payer and hold those payers accountable for erroneous denials. For example, most payers have the exclusion if a patient leaves against medical advice, which is 07, that's the discharge code. If they leave against medical advice, then the subsequent admission is not considered a readmission and is eligible for separate reimbursement. We have seen cases, however, where the discharge code on that anchor admission actually said that the patient went home rather than the true fact that they left AMA. So sometimes just correcting that discharge code may get that readmission denial overturned. So again, that's just one little tip there. So post-payment audit, right? So you think everything is good, right? Everything is good with the claim, you billed it, it got paid, you closed it a long time ago. But suddenly you get a letter from the payer in the mail saying that they conducted an audit and they want all or some of their money back as they process that claim in error. Typically, the reasons that they seek a refund after audit are due to a lack of medical necessity for that level of care regarding the admission status, or it could be a level of care for a bed type issue, ICU, for example, versus a med surg rate. We see a lot of denials for the various NICU levels, 1, 2, 3, and 4, where they're saying they really only approved level 3, but you guys billed level 4. So there's those types of level of care denials as well. Another type of post-payment audit are the DRG reassignments or DRG downgrades. Payers will review and determine that a specific diagnosis or diagnoses or a procedure code are not supported by the medical record documentation. And by removing or changing that diagnosis or procedure code, it then changes the DRG and therefore the reimbursement to the hospital. These DRG downgrades can be due to two different types of audits. One is a DRG validation review. The second is a clinical validation review. So what's the difference? Well, the DRG validation really is a review to ensure that the diagnoses and procedures coded and billed on the claim matches the physician's description and information contained in the record. A clinical validation is a review done by clinicians to determine if the documentation in the record matches the codes billed, but they're looking for the specific clinical information, whether that be lab values or vital signs or diagnostic test results that further support that that diagnosis was valid and that it was treated. Please know that there are state statutes that set a limit as to how far back a payer can go to audit and request a recoupment of funds. In addition, hospitals and payers can also contract for a time period which can be less than the state limit, but certainly not longer. When you receive a letter from the payer stating that an audit's been done, your first step should always be to make sure that they are compliant within this time period. Make sure they're not going too far back in time. So now let's get to denial prevention and get into the root cause of these denials so that we can prevent them going forward. So getting to the root cause of a medical necessity denial requires you to look deep into what happened, and this includes looking at your patient accounting system, your case management notes, and the medical documentation. You must keep asking the question why. You know, my mantra is typically it takes 5 whys to get to that true root cause. So let's review a situation where the request for inpatient level of care was denied at the time of request when it was sent to the payer. Especially with medical necessity denials, the root cause cannot be identified just looking at the reason for the denial, but we've got to dig deeper to figure out what really caused that denial to occur. Again, those why questions, such as, did the payer get the clinical information to make the right determination? Did the clinicals provided have the detailed information to demonstrate, again, that severity of illness, that intensity of service? Did the payer have direct access? If so, what did they access to make their determination? What did they review? You should be able to see what they're reviewing. And we discussed this earlier. Do they have access to the full medical record, or are we just releasing certain portions? So we had a case where the records were released to a payer, but the hospital was only releasing from the time of admission forward, not the ER records. Well, if you think about it, the ER records is when the patient presents to the ER, that's their sickest. That's when they are the sickest. So we really need to send those ER records, like when you release those records or send those clinicals to the payer. When criteria is not met, was there a secondary review done by a physician to make a decision for level of care? Right, so your UR nurses, they have to look at Milliman or Interqual to make that decision. And if it doesn't meet, it needs to go to a physician for that determination and the rationale behind it. Does the physician documentation support the level of care? Are there words being used, such as observation, that would give the indication that inpatient level of care was not necessary? Or do they provide the rationale and the detail to support it? Was there a delay in treatment? I talked about this a little bit earlier with the length of stay denials. Even though there may be a delay in treatment or a delay in a test being done, that does not automatically mean that that patient could have gone home except that the test wasn't done. In many cases, that's not true. The patient is still sick enough to be there and needs ongoing treatment, and that delay in service did not in any way extend what would have been that length of stay anyway. Was peer-to-peer done? If not, what was the reason? Were you outside of the time frame? Did the physicians not able to connect due to scheduling issues? If it was done, what was the outcome? Was it overturned? We have seen many cases in which denials were overturned on peer-to-peer, but that information was not updated in the payer system. So when you build that claim out, they still had that it was denied, right? So the physician, the UM team at the payer somehow did not get that into the system. And it's often just a phone call. And they'll say, yep, I see where it was overturned, and then they will reprocess your claim. The timing of the inpatient order, talked about this a little bit. Was it written within hours or the same day of discharge? If so, I would relook at that case. Did it truly meet medical necessity for inpatient if they went home in just a few hours? So again, just a tip to maybe put in a process to maybe look at those. Continuing on the denial prevention strategies and actions we can take to reduce denials, the hospital case managers or your UR nurses, they should be reviewing those observation admissions every day to determine if the patient is stable for discharge or do they need to remain in the hospital and warrant a change to inpatient status. It's not enough just to send the criteria or the guideline. Again, we need to send them the detailed clinical information to support that medical necessity. If only so many days are approved and the patient remains beyond that date, make sure they get access to those ongoing records and those concurrent reviews. And if you still get a denial, utilize the peer-to-peer process when available because there has been much success with that process. Documentation is key not only to overturning these denials, but also preventing them. Physician documentation, as I have stressed, must demonstrate how sick the patient is and the treatment plan, but also those other factors such as comorbid conditions and the physician judgment. Physicians should refrain from using, again, the word observation in their notes. We do see this a lot. And we understand as clinicians, I'm a nurse, we understand that what they mean is we have to still monitor this patient, right, closely because there is a concern that the patient could deteriorate or some sort of adverse event could happen. So rather than using your patient requires continued observation, have your physicians consider using phrases such as need for continued close monitoring due to patient is high risk for an adverse event, or close monitoring required due to cardiac instability and need for emergent intervention. Those words make all the difference to make your point. And again, as I discussed before, those length of stay denials, especially for delay in discharge, documenting your efforts, but also remind your other disciplines, nursing, therapy, respiratory therapists, that their documentation is also key when we're trying to prevent these denials, let the payer see what's really happening. And it's at that level that you get the detail of any respiratory issues or any physical issues that's maybe impacting a safe discharge or where they need continued care and treatment. So those ancillary department documentation is also very important. So let me turn my attention now to outpatient denials. Payers will deny services as experimental or investigational when they deem that the service does not meet their medical necessity criteria per their policy. So these terms of experimental and lack of medical necessity are truly interchangeable. Payers, all payers, have very specific policies that specify the criteria that must be met for them to consider a service or a test medically necessary. There's also Medicare national and local coverage determinations, known as NCDs and LCDs. Some services require failed conservative treatment prior to surgery, right? Or they require lower level drugs be used before the higher level drugs, right? A tiered approach. So understanding your payer policies is important. So this would be like for your physician practices, for example, when they're trying to get that authorization. But we're also seeing an increase in denials for site of service. So site of service are when the payer approves the service, but they only want to approve it at a freestanding center and not in that hospital outpatient setting. There must be documentation to support that the service could only be done in the hospital setting rather than a freestanding diagnostic or infusion type center for whatever the reasons are, whether it's risk factors or whatever. It's important to know when you're getting these authorizations, where are they approving the service to be done? So they may say, yep, I'm approving that MRI. Ask them where. Is it at a freestanding diagnostic center, or are they approving it for the hospital outpatient setting? It's also important when you're looking at the policies, especially when we are appealing these, that we look at the date of the last revision to that policy to ensure that it's current with today's standard of care. So we did have an issue with a payer where they were denying all of these echocardiograms, a portion of these echocardiograms, saying they were not medically necessary. But they were the only payer denying. So when we dug deep and looked at their policy, we recognized that it had not been reviewed in 3 years. When we brought that to the payer's attention, to the medical director, they actually revised their policy, agreed it was outdated, revised it, updated their policy, and then re-reviewed all the claims and actually paid them. So again, knowing, is that a current policy? Are they using the correct policy? Is, again, very important. So Stacey, I turn it back to you. Are you there?
Hi. I want to talk a minute about some legislation and as it impacts those outpatient denials that you were just talking about. So the legislation that states are enacting today, the few out there, they're trying to remove that administrative hurdle, particularly on the outpatient side. An example that would be addressed is when we have a scheduled procedure, we get the authorization for that procedure, but when the procedure is actually performed, the physician determines, oh, I must add this, or, oh, you know what, we really need to do this. This is the medically necessary procedure to do. And authorization is not obtained, right? So when the claim is billed, we get a denial. In the old days, if it was a situation where maybe it was an MRI with contrast versus an MRI without contrast, the payers would crosswalk because those codes were related, and they would crosswalk, and we'd get those claims paid without issue. But today, claims are being denied if the billed CPT is not the exact match to the authorized CPT code. So, the Ensuring Transparency in Prior Authorization Act that I talked about earlier, several states have this provision that you see on the screen here where they're saying, right in the statute, for those unanticipated services which are incidental to the primary covered healthcare service and determined by the physician to be medically necessary, you don't need authorization. That service should be paid. So, it's so very exciting, and I know we don't necessarily have this everywhere yet. When I was doing my review of the states here today, Washington has a similar rule in place entitled Extenuating Circumstances in Prior Authorization. That provision, that statute, basically says that payers must have a policy in place to account for 3 specific extenuating circumstances, and this situation here, when a facility is unable to anticipate the need for a prior authorization before or while performing a service, is one of those extenuating circumstances. So that is fantastic. But again, that was just Washington. And then this legislation that is going around, it's just a handful of states. But that's okay, because remember, we're going to take denied authorization situations and we're going to bring it into the realm of medical necessity. And this is one of the easiest situations to do, because you obtained authorization for a service, and something incidental to that in the sound medical decision-making of the physician said something else had to be done. Put that in your appeal. You don't need to cite a statute. You don't need to cite any contract language. This is just we're over the administrative burden because you obtained authorization, but these are the extenuating circumstances. So with that, let's talk about how we fight these denials. And we start with appeals. We're going to talk about appeals for just a few minutes and how we approach them today versus how we used to approach them. Remember, medical necessity denials is where the payer is inviting you to overturn these denials. So we have to really think about the argument we're making and how we're going to persuade them to see things our way. We're going to start with appeal organization, and then we're going to talk about writing for our reader. So appeal organization, number one, get that denial letter, right? Lori is a big proponent of first things first, get the denial letter. It's going to cite the clinical rationale for that denial. And most of the state statutes that I looked at in preparing for this did have a provision to say that the payer does have to provide you with that, so request it. Next, the burden of proof, right? So you do need to prove your patient is not the typical, okay, because the payer's decision-making will be based on typical patients. You need to prove your patient is not typical, and hindsight is 20/20. Don't let the payer look at the complete record to say, oh, yeah, now that we know this, the physician should have done this. No, 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 no. You need to bring it to where the physician was when he or she needed to make a decision. The rules that you might be citing, Interqual guidelines, minimum care guidelines, again, these are guidelines, not rules really, contract language, any rules, regulations, throw it all in there. We need to beef up our appeal. And then we need to organize it in a way for our reader. I think we would all agree that social media has changed how we absorb information. Everything is in short little snippets, whether it's a quick news blurb, a tweet, TikTok videos are 60 seconds long. We absorb things. Our attention span is much shorter. I'm not saying the payers aren't paying attention to our appeals, but our natural inclination for all of us nowadays is to skim read. All right, so really try to make your argument as concise as possible. State your conclusion up front, why this is denied, why you disagree with that denial, and what you want. Do your analysis, but draw the payer's attention to certain portions of the medical records. Underline things, bold things. Don't highlight because it doesn't scan well when they bring it into their system, but draw their attention on your front page, if you can, to the highlights that you want them to see. If they're only going to skim read, these are the things you want to catch their eye. Now, denials can still be upheld, right? But we're talking about medical necessity denials. We're not talking about whether or not there was a policy in place. We really need the opportunity to take these to that next level. A lot of times you need to go to your joint operating committee meetings with these. And your payer contracts should afford an opportunity to escalate these types of things. This is one area where verbal communication on these topics, when you have the right people in the room, you can have tremendous success. Lori just gave you an example where we were able to get a payer to acknowledge that their policy was out of date, and then they went and they reprocessed our claims. We didn't do that through individual appeals being submitted to the appeals review department at that payer. We had to bring it all together to a joint operating committee meeting, ask that the medical director attend, and then have a discussion and explain what we're seeing from them, what we're seeing from other payers. And then with that discussion, the medical director went back, did his research, and then came back. These meetings are effective, and we're experiencing some hospitals that aren't making the most, thinking we can't bring clinical denials to our JOC meetings. Yes, you can, and you really should, because these are the types of issues your clinicians want you to bring. They're making those decisions that this treatment is medically necessary, and they want you to fight for every dollar that you can. So with that, thank you very much, and I turn it over for questions. Oh, Lori, go ahead.
Yeah, I was just going to add that we also had a case where the physician doing the review of the appeal was not really qualified to do the review. There was a long-term care physician. We also took that to the payer meeting, and their medical director re-reviewed and overturned those cases. So it definitely is effective.
Definitely. And I'm going to go ahead and change to this since you didn't see it before. Thank you. Any questions?
Actually, this is Bob Cologne. There are actually like 12 questions. One just came in. We can go through them quickly. I know that we're running out of time. But the first question, and this came in early in the presentation around slide 7, which is when we were discussing prior authorization legislation. The question was, what about authorization for the emergent admission? That's the first question.
So right now, there is nothing that I've seen that would change the requirements of EMTALA, such that you cannot ask for the insurance information before a patient is medically screened. There are contractual requirements and state statutes that say once that happens and you're making the decision to admit that person inpatient for ongoing treatment, that typically it says you must do that within 24 to 48 hours of that admission.
Okay. The next question came in around slide 10, which was when we were discussing clinical documentation. And the question was, when we research if pre-auth is needed and insurance indicates no auth needed, but then deny the claim when we bill it, any suggestions other than giving them the evidence of them saying no auth needed?
Well, step one is giving them the evidence. Absolutely capture that, whether it's a screenshot or you've documented, you have the name of somebody, or you have, it was an online portal that gave you that. Absolutely, that evidence is so important. The next thing is there is a legal principle. It's recognized through courts throughout the country. It's called promissory estoppel. And basically the argument is if you rely on a promise that somebody else makes, somebody that's in the best position to know the information, and you rely on that to your detriment, you should not be penalized. So in this case, the payer knows whether or not authorization is needed. You went to their system, you verified, you contractually did what you were supposed to do, and you got the information from them saying no auth needed. So you relied on that and performed the service. So the argument is, based on that, they're obligated to pay. You met your contractual burden.
The next question came in around slide 11, and the question is medical necessity. I like to reference NIH article proof in my appeal letters when available, or medical organizations specifying in that disease. Any other suggestions?
So I can take this one. So, I mean, that is great information to include in your appeal, but also understand that the payers have their own medical policies with the very specific criteria that they are requiring to prove medical necessity. You can use that standard of care that you're referencing here in your argument, but I would also try to tie it into their medical policy if you can make that meet that way as well.
Okay, the next question around slide 12, which was the slide talking about UHC transitioning to Interqual. And the question is, the Milliman and Interqual criteria are single disease process specific and do not take into consideration the entire patient. The question is, how do we use the combination of all the disease processes to avoid the denials?
So a couple of ways, and we talked about this, right? The Interqual and Milliman are just strictly guidelines, right? And they are very disease specific. But if you can get it to meet by several, like COPD as well as pneumonia, I would throw that into that appeal process. But also looking at those comorbid conditions, throwing in the risk factors of the patient and that physician judgment. So again, they're just guidelines. And we just need to prove the point, as Stacey said, and prove that this is not a typical patient, right? This patient has 3 different conditions that we're treating concurrently, and so you need to make the point that way.
Okay. Do we have time for more questions? I saw Holly's thank you note. can we continue on or do we have to end? I'm assuming we can continue going.
You can continue. Go ahead and
Okay.
continue.
Okay, thank you. So the next question came around slide 15 when we were talking about length of stay. And this one was more of an FYI. Recent trend, insurances challenge secondary diagnosis code when it factors into the DRG calculation, impacting coding workflow. I believe that was more of a FYI included to the presentation. The next one came in around slide 17 when we're talking about inpatient denial readmissions. And the question is, what about denials for readmission when it is the fault of the patient due to non-compliance?
So I would be arguing that fact just on its face alone, that the patient was non-compliant, right? It was due no fault of the hospital. It wasn't due to lack of, correct or appropriate care or post-discharge planning. But also look at the payer policies, because many payers do have non-compliance as an exclusion to a readmission denial.
The next question came in around the same time, and I believe we were talking about DRG downgrades or audits at the time. And the question is, how long do payers have to do a post-payment audit?
So that is state regulated. It's usually in the same statute as you would find for your prompt payment statute. And we've seen anywhere from 12 months, up to 3 years. It can be up to 5 years if it's an ERISA plan. But you would have to check your state statutes as that baseline and then your contracts to see if you contracted for a shorter time period.
Next question, we're almost done. Next question was around slide 23. We're back to talking about prior authorizations. The question is, which states have the authorization statement that is being discussed?
So I believe that has to do with the outpatient and removing that administrative hurdle when it's a procedure that was incidental to the authorized service. And the states that I've seen it in, besides the one we cited for Washington, Ohio, Georgia, Montana had the opportunity to enact that when they did their prior authorization, but they did not. And then I believe New Jersey is considering it right now.
Okay. So the next question was, does California have the insurance transparency and prior auth legislation yet?
I did a double check this morning, and I do not see that is currently with the legislative body, so no.
Okay. The next one is more of a request. It says, please define the abbreviations that are used in the body of the handout and discussion. Example, what is JOC?
Sorry about that. JOC is Joint Operating Committee, and it is the usually by contract where it provides that hospital representatives along with key payer representatives will come together to meet the ongoing business relationship and address any issues, typically on a quarterly basis, and they call that meeting a Joint Operating Committee, JOC.
And we got more questions. So here's another one. So what is your recommendation to overturn a denial for medical necessity due to experimental?
So you have to be looking at the payer policies to see if they have one, and if so, is the criteria that they're requiring supported in your medical record? But along that same lines, if it's not, are there other payer policies, right, where maybe they do pay it? If it is a new treatment or something that's kind of emerging, right, because medicine's always changing, look to see, is it FDA approved and is it truly the standard of care? As we talked about earlier, you can throw some of those articles by those specialty organizations in to support the medical necessity of a service. But I would start with the medical policies.
Okay. The next question came in. How do you suggest handling form template appeal denials where they don't even read your appeal and exhaust an appeal right?
So this is that exact situation that I said is perfect for medical necessity denials and the Joint Operating Committee meetings. We escalate things. We encounter those denials where you're like, did you even read what we wrote? We made a great sound argument and your response doesn't address anything. And we continue fighting. We have developed relationships, alongside our hospitals with the payers, right, with their provider representatives. And so we're not taking everything to the provider representative, but for those situations where we know we have a winning case and the payer didn't even read it, we escalate it up to our provider representatives. Whether it goes to a JOC meeting will depend on the situation. Sometimes we just get another review based on the relationship that we have.
Next question is, this is a good one. We did a case study on this one, but last example that the reviewer was not qualified. How did you know about the qualification of the reviewer? Can you please expand on this?
Yeah, so how we found out was every denial letter, as Stacy said, if you can get that denial letter, it really does provide you critical information, not only to the clinical rationale, but who reviewed it. In this case that I was referring to, it was signed by a physician who is the medical director of a long-term care facility. But we have also seen denial letters where it was just done by a claims representative. So it's a signature on the letter that clued us that this person did not have the qualifications to be reviewing an acute hospital appeal.
And then one other point, Lori, that was the situation where the payer outsourced that to a third party. And so the medical
Correct.
Director had to do some research as to what that third party, who they actually had doing their reviews. And so this particular hospital no longer has their reviews done by that third party.
Next question is, suggestions on handling a no-auth needed response from the payer, but it is in fact really a benefit exclusion, not that it does not need an authorization.
So one of the disclaimers that payers will stand behind and courts have supported for the most part is the, when you get an authorization, it's not a guarantee of payment. It still must go through the benefit review part. Authorization, benefit review, two separate phases that need to be met. So you could get an authorization for a service, but if that is not a covered benefit under the plan, you're not going to get paid.
Next one is, what is the act that provides the definition of medical necessity by state?
So again, this is something new, right? Only Medicaid has been defining medical necessity in state statutes. So the enabling, the Ensuring Transparency and Prior Authorization Act is really a model legislation sponsored by the AMA that their lobbyists have really been pushing, and certain states have taken it up. But if you see Ensuring Transparency and Prior Authorization Act, a definition of medical necessity is a part of that model legislation.
Just three more questions, I believe. So if payer is required to pay, this is off of slide 16. If payer is required to pay for non-authorized days, under what categories?
Lori?
I'm not sure what the question means by under what categories. So regarding the non-authorized
bed type rate, so would they be paid, obviously not at an ICU rate? Are there being negotiated payments for those unauthorized days? Is it skilled nursing rate? What would be for those delay in discharges?
For the delay in discharges, what we have seen is for the bed type level of care, the ICU, it's really looking to see did they meet that level of service like for the NICU levels. But for your length of stay denials, in some cases we would agree, right, that inpatient's not met, but we had to keep the patient in the hospital, right? So we have looked at single case rates to try to get the payer to agree to pay a single case rate at that skilled nursing rate. Some payers have agreed to do that, and now hospitals seem to want to put that in their contracts so that when you have those types of situations, there's at least some reimbursement to the hospital.
Okay, two more questions, and this one reads, any comments regarding the coding downgrades from the Optum EDC analyzer?
Yeah, so that's for the emergency department claims, right, where Optum has that analyzer to determine what level of ER visit. We've actually had a lot of claims kind of being denied based on this reason, saying that the level billed is not supported. And we have actually, we're fighting with some payers because in our view that analyzer does not take into account all of the factors that go into determining an ED level of care. So you really have to argue your point as far as the coding of that level and to prove that all those points that are required is supported by the medical record documentation.
All right, final
and we're
question.
also doing, sorry, we're also doing those in bulk, right? Because sometimes your ED claims are lower balance. We're doing them in bulk to fight those. Sorry, go ahead.
This is the last
Correct.
one, and we're done. I'm sorry to continue on, but this is the last question. Denial for experimental. The question is, does cite other payer policies equal citing other insurance companies' policies?
So it's one and the same, right? When we talked about citing payer policies, right, it can be, and we have argued in some cases, not often, because most of them typically are current policies, but we have argued with other payers where they are paying for a certain service where it meets their criteria to prove that that payer is kind of an outlier and that their policy is not current. So in some cases, that would be appropriate to include in your appeal.
Okay, that is all the questions we have. Thank you. I'll turn it over to Region 11 representative who wants to close out the meeting.
Hi, so this is Tammy Dumlao, the RE for Region 11. Thank you for staying on, and thank you for attending today on behalf of Holly, the Nevada chapter, and Region 11. Special thanks to Stacy and Laurie. This was wonderful. So everybody, please remember to register for our next regional webinar. That's going to happen on May 11th. It's called the MAP Journey from MAP PP to MAP Award. Aloha, everybody, and have a great day. Thanks.
Thanks, everybody.
Thank you.